everyone, and a big thank you for being here today. I am Saxena, along with my colleague, Dr. Deepika Chabra from Medical Services, on behalf of Jagsonpal Pharmaceuticals Limited, would like to extend a warm welcome to the experts and the attendees for joining this fourth stage of labor, the art and science of birthing, part 9, scientific Sangam 28, organized by ISOPARB Prayagraj with Allahabad and Baroda of Gynaecological Societies and Jagsonpal Pharma Ltd, makers of Divatrone, injection Maintane and Divagest. Please note this webinar is granted 3 ICOG points. We would like to present our Divatrone 10 mg tablet, fully indigenized, micronized by dydrogesterone, the only brand having 36 months of shelf life. We also like to present you the range of natural micronized progesterone as Divagest. Jagsonpal would like to thank experts and attendees for joining us today. This webinar, 4th stage of labor, the art and science of birthing, part 9. Dear attendees, if you have any questions, suggestions, clarifications, please post it in the chat box or in the Q&A box. And if you want to speak up, please raise your hands. For today's webinar, the art of science of birthing, I would like to welcome organizing chairperson, Dr. Ranjana Khanna ma'am. Ma'am is the founder, president, ISOPARB Prayagraj, and she is also the ICOG governing council member. She was the vice president of FOGSI 2017. Ma'am, I request you to please start this session.
Very good evening to all. I'm really delighted to present this 10 ultimate in the series of art and science of birthing. But before we begin, we pay our obedience to Lord Shiva. A very warm welcome to everyone. And first of all, I would like to introduce our chief guest of the program today, Dr. Narendra Malhotra. What to say about Dr. Narendra Malhotra? He is, we've heard of the saying, jack of all trades. But Professor Narendra Malhotra seems to be a master of all trades and a jack of none. Initially, we were all overawed by him because of his obstetrical skills, his gynecological skills. Later on, he impressed everyone with his knowledge of fetal medicine, and now it's cosmetic gynecology. So I think wherever any branch offshoots, Dr. Narendra Malhotra becomes the master of that. So welcome, Dr. Narendra. It is really a pleasure to have a multifaceted personality, a leader like you to our program. He's been the president FOGSI in 2008, I remember. So I can't see it anywhere in this, but I think it was 2008 in Delhi you became, na, Doctor? Yeah, I was there and I attended that grand function. And he's the managing director, Global Rainbow Healthcare, director, ART Rainbow IVF, president in SARG and vice president CHAIRPERSON and WAPM, and he has been the past president of ISAR, ISPAT, IFUMB, FOGSI, AOGS and ICMU Dean. So he's the director, Ian Donnell School of Ultrasound, and so many things. He's editor of CHAIRPERSON Journal, member of FIGO Guidelines Committee, director, Manita CSC, chairman Smriti. And
thank you, madam. Thank you.
So, Dr. Narendra, I would love it if you could just give your words of blessings to our webinar.
So, greetings to all of you. Absolutely good evening. सबका ये गणेश चतुर्थी का हफ्ता जो है शुभ निकले और हम लोग सब अच्छे से एक दोस्ती जैसे परिवार की तरह रहें, यही मेरी सबके साथ शुभकामना है. So today what you're discussing is what I came to know is about labor, and you've been doing it since all the stages, and we are coming to the 4th stage, and the 4th stage is this. So the 4th stage of labor is very, very important. And I'll send you what we do is even when we do cesarean section, the fourth stage, we start by putting the baby, a patient is under spinal, baby on breast. So what we call as breast crawl.
Yes.
And that is the first thing which all of us should learn. See, most of us are doing cesarean in a very hurried way. Jaldi jaldi बच्चा निकालो, काटो, फेंको, फिर जल्दी से प्लेसेंटा खींचो, जोर से यूट्रस के अंदर रगड़ के साफ करो. That is not the way to do a cesarean. So you have to do very calmly, nicely. When the baby comes out, put it on mother's breast, cord, delayed cord clamping. कुछ नहीं होगा, कोई bleeding नहीं होगी, कोई PPH नहीं होगा. By the time your carbetocin is acted, your prostate or whatever is acted, in which you give for fourth stage of labor, don't pull the placenta out. Placenta will deliver on itself. And very nicely it comes out, and then just gently clean inside the uterus. कोई जोर से scrub करेंगे तो we cause endometritis and we cause Ashram for future in this thing. So that is what we got to learn. All of us practitioners have to learn how to be patient. I also started doing 7 minute में Caesar skin to skin करना है, but that should never be your this thing. आराम से करो, आधा घंटे में करो, but do it nicely, so that the patient gets. And of course, always give a transverse, low transverse horizontal scar, not even a curved one, which hides into the hairline, because women cosmetics has to be respected there. And if she has a striatum mark or keloid formation, we are also doing the stem cell treatment at the time of cesarean in the scar before we stitch the skin. And we make these stem cells out of the wart and jelly from the cord of the patient also. At the same time, जब तक uterus stitch हो रहा है, वो cord blood का wart and jelly से उसको wash करके you can make, and that's a protocol which we'll talk someday else. And you can inject it under the skin and you get a very beautiful scar. And then the rest can be injected also in the striae gravidarum, and the striae also vanish or reduce. So that is some things which you all have to learn. Now I have learned it. That means I'm not going to hide it. I have to share this knowledge. So knowledge, the doors of knowledge should never be closed. The doors of knowledge should always be open, and youngsters should come and learn and respect the knowledge and the experience and tell us of what new is happening, what they come across. That's how education will spread. So thank you, Dr. Ranjana, for inviting me here as chief guest. Thank you very much. All the best for this webinar. All the best to all of you in your future endeavors, and to you especially in your future endeavor this year. Thank you very much.
Thank you so much, Dr. Narendra. And these were truly words of wisdom, because these things that you have just said, I wasn't aware of it. So it was indeed very, very enlightening for us all. And thank you once again. And now I think I'll hand over the session to Dr. Abhilasha Kumar.
Good evening, everyone, and a very warm and hearty welcome to all. And we begin the first session. And the speaker for this is none other than Dr. Ranjana Khanna ma'am. And the topic is introduction of the fourth stage of labor. And I would like to invite the chairpersons, Dr. Sarveshwari Nautiyal ma'am and Dr. Manisha Goyal, to chair the session. Dr. Sarveshwari Nautiyal ma'am is a much loved personality, and she is the founder and managing director of Kishori Foundation, which is a pan-India NGO. NGO work is focused on conducting screening programs and awareness camps in the rural as well as the urban areas of Uttarakhand for early detection of breast and cervical cancer. Previously, ma'am was the Director Medical Health Services in the government of UP, and she was consultant and colposcopist at the Regional Cancer Detection Center, TB Sapru Hospital, Allahabad. She has been a co-guide for MD Pathology thesis at MLN Medical College, Allahabad. She was the Superintendent-in-Chief at District Women's Hospital, Allahabad. Organized clinical research screening camps for thyroid disorders in antenatal cases for PGs in the Department of Medicine, MLN Medical College. She is the principal worker for a project for AIMS, New Delhi, on screening program of hypothyroidism in the newborns at District Women's Hospital at Gorakhpur. She has life memberships at the UP chapter of FOGSI, IMS, International Red Cross Society. She is a member of Breast Committee, and she has been faculty in various national and state conferences. Her fields of interest include early detection of breast cancer and cervical cancer, screening camps for thyroid disorders. Welcome, Nautiyal ma'am. And our other chairperson is a very dear friend, Dr. Manisha Goyal. She is a senior consultant and director of Shikhar Hospital. She is life member of FOGSI and member of ISOPARB Prayagraj. Welcome, Dr. Manisha. I would request Dr. Manisha to please kindly introduce our stalwart speaker, Dr. Khanna ma'am, and something on the subject, the topic. Dr. Manisha.
Thank you, Dr. Abhilasha. Dear friends and our senior doctors, for centuries, millions of women lost life due to misunderstood and mismanaged fourth stage of labor, which is the period within the 1 hour after the expulsion of placenta. For the last few decades, the focus of obstetrician has been on this fourth stage, which has drastically reduced the maternal mortality rate in India from 556 women dying during childbirth per 100,000 in 1990 live births in 1990, and it is reduced to 97 deaths per 100,000 live births in 2020. Now our most prestigious and renowned speaker, Dr. Khanna, will enlighten us on this most crucial fourth stage of labor. Dr. Khanna, madam, she is a senior consultant and director, Ranjana Hospital, Prayagraj, and she has been National Vice President FOGSI 2017, Founder President ISOPARB Prayagraj 2021-2023, ICOG Governing Council Member 2021 to 2023, President AOGS Allahabad from 2013 to 2016, organizing chairpersons of various FOGSI conferences, national FOGSI conferences like Scientific Sangam, Obstetric Dilemmas, BOH, and organizing secretary National FOGSI Conference SEMA 2016, receiver of various national awards, FOGSI Achiever Award 2022, FOGSI Dhira Award 2022, FOGSI Dr. D.K. Tank Reproductive Healthcare Promotion Trophy AICOG 2015, FOGSI Smriti Mylan Award Save the Girl Child.
Thank you so much, Manisha, for this lovely introduction. So, good evening, friends. In my last webinar, the topic of the webinar was the third stage of labor. And then I had asked a question, is this the grand finale? Well, the answer was no, because now what we are dealing today is actually the grand finale. So when we were students, when I was a student and I was doing my post-graduation, there were only 3 stages of labor. The first stage, the onset of uterine contractions till the complete dilatation of the cervix. Then the second stage, from the full dilatation of the cervix to the expulsion of the baby. And the third stage was from the expulsion of the placenta and the membranes. And then it was all over. So very happily, we would say that the delivery is now over and the patient was then shifted to the wards. So now that was where a little bit of carelessness would creep in, that the patient is now fine. And then sometimes it so happens that any incidence of heavy bleeding, that is PPH, would not be discovered till very late. So we missed that golden period, that golden 1 hour to save the patient's life. We would not come to know about the PPH till very late. And then it would be actually very late and very difficult to save the patient's life. Similarly, it happened for the newborn children. Child was born, and after that, the child became cyanosed, apneic. Nobody came to know because the child was in the ward and the baby's head was also covered. The baby was lying under the sheet and it was all not discovered. And this was responsible partly for the maternal and neonatal mortality. So now it is taught that actually the labor is not ending after the third stage. So we can say that picture abhi baki hai mere dost. And this is the fourth stage of labor in which we have to be very, very careful. We have to check the vitals of the mother. We have to take care of the newborn. And that is when we are not complacent, we end up utilizing the golden hour and hence decreasing the maternal and the neonatal mortality. So we will begin this subject. The recovery phase immediately after delivery of the placenta often is referred to as the fourth stage of labor. This is actually a misnomer because labor and delivery are already completed after expulsion of the placenta. The fourth stage is the critical time beginning after delivery of the placenta, and this ends when the maternal system has stabilized, usually around 1 to 2 hours later. So how do we define the fourth stage of labor? The hour or two after delivery, when the tone of the uterus is re-established as the uterus contracts again, expelling any remaining contents. These contractions are hastened by breastfeeding, which stimulates the production of oxytocin. And we know how important that is for contraction of the uterus, retraction of the uterus, involution of the uterus, and above all, the feeling of warmth to the baby because it initiates the suckling also. The birth of the placenta marks the beginning of the very important but little known fourth stage of labor. Both the mother and baby are at the highest risk of complications related to birth. The necessary process of bonding and initiation of breastfeeding must start. So what are the signs and symptoms? The patient has just delivered. She has lost blood. She has been in terrible pain. And she's got tremors and chills, discomfort from pain because of episiotomy, tears, maybe hemorrhoids, weakness and dizziness, especially orthostatic hypotension is there. And when she tries to stand, she feels very dizzy, difficulty during micturition because of swelling in the genital area. How do we manage? Patient is kept under constant supervision. It's not that we just send the patient to the ward and then we are over with that. No, the patient has to be kept under constant monitoring. Her vitals, her pulse, blood pressure are regularly monitored. Blood loss is assessed. We all are very well aware that more than 500 ml of blood for a normal delivery and more than 1000 ml blood for a cesarean are the cutoff when we label it as a PPH. But we say that nowadays, if the patient is very anemic, say she already has a starting hemoglobin of 7 to 8 grams and she comes for delivery, then 500 is too much of a blood loss for her. At 300 only her vitals will become unstable. She'll become totally hemodynamically unstable at only 300 ml blood loss. So we consider PPH as that level of blood loss when the patient's hemodynamic stability gets altered. So this is our criteria. Now we have shifted her to the ward, but we keep on watching for the blood loss. And first of all, what do we assess is the uterine tone. Just feel per abdomen for the uterus, whether it is well contracted or not. And now if the patient continues to bleed, shift her again to the labor room and expose her perineum. Now we start by examining the perineal skin. Any signs of tear? If not, then go on to the vaginal skin, then examine the anterior vaginal wall, the posterior vaginal wall for tears. If they are, you repair them. Sometimes there could be very tiny paraurethral tears. You know, they are so tiny in size, but the amount of bleeding because of the blood, the vasculature there, it bleeds like anything. So we have to be very careful and look at that area also, because sometimes when the uterus, the baby head remains impacted over there, so she can get a tear that side also. And then now we have seen the vagina, but still she's bleeding. Then we have to examine the cervix. Now, how do we look at the cervix? We take 2 sponge holding forceps or ring forceps as we call them. One is on the left side, one is on the right side. See that portion of the cervix, then shift the left sponge holding forceps towards the right, and then see that portion of the cervix. If we happen to find a tear, then place one sponge holding forceps on either side, and we start repairing after we identify the apex of the tear. Now we take one stitch either with Vicryl number 1 or with chromic catgut number 1. We take a bite just above the apex, and then we can take a continuous suture. But suppose we can't see the apex, suppose it's higher up, then you take a suture wherever you can see and then give gentle traction to the catgut, and then you will see the tear, the apex of the tear, and then you can stitch that portion also. So now you've repaired the cervix also, and now we have to see, and of course you will have found out whether there is any tear if the uterus is well contracted. So uterine tone is there are 4 T's we all know. It is tone, trauma, tissue, and of course thrombin. That is the coagulation disorders. So we have to be very sure that we have not left any pieces of placenta behind. So if that is the case, then in that case, we will have to do gentle finger evacuation, or we can even take the help of sponge holding forceps. But be very careful so that you don't perforate the uterus. Be very careful in that, and we must remove all the remaining pieces of placental tissue or the membranes which could be there. Now, so we have talked about this, and blood pressure, uterine blood loss and pulse rate must be closely monitored, and high risk of PPH from uterine atony, retained placental pieces or lacerations. We've just discussed this. Now, pain is a very important feature after delivery. Assess the type, intensity and localization of the pain. Cramping may occur because the uterus tries to now involute, because it is under the effect of oxytocin. It tries to involute, and these are also known as the after pains. These are crampings may occur, and lochia rubra is seen on the pad. Patient may experience chills, which could be a response to thermoregulation. Now, how do we evaluate the uterus? After delivery of the placenta, the uterus is normally found in the midline of the abdomen, about 2/3 or 3/4 distance between the symphysis pubis and the umbilicus. If the uterus is above the umbilicus, it indicates that there could be presence of blood clots which need to be expelled. A uterus above the umbilicus, slightly to the right, could be because of a full bladder. Uterus is assessed every 15 minutes. Consistency of the uterus, whether it's contracted or not. If not, we can do a gentle massage to rub up a contraction. Now, suppose we are not able to rub up a contraction. Patient is continuing to bleed and the uterus is flabby. Then in that case, we have to use oxytocics. And what is the oxytocic of choice? We have oxytocin injections, which are put in we can put it in ringer lactate or normal saline, and we start the drip at 20 units, wait for 10 to 15 minutes, see whether it is contracting or not now. And now if the uterus is not contracting, we can add on other oxytocics like ergometrin can be added on. And besides ergometrin, we can also take now the second line of drug is misoprostol. So misoprostol, in this case, when the patient is bleeding, it's better to give it sublingually. Just put it under the tongue. There the vascularity is so good, and the absorption is so quick. So just put 400 to 600 milligrams of misoprostol under the tongue of the patient, and you'll have a beautiful response. And another drug which can be used is injection carboprost. The only drawback of carboprost is it gives beautiful response within 2 to 3 minutes, but the only drawback is that it can lead to vomiting in the patient or loose motions. So examination of the newborn. Now we have to examine the newborn. The Apgar score is taken at 1 and 5 minutes after birth. Normally, we are always careful to get a neonatologist at hand to look after the baby. And the heart rate, respiratory rate, and color are used as basis for resuscitation. Now, suppose the pediatrician has not yet arrived and the baby started getting cyanosed. We can always take the help of the anesthetist if we are doing a cesarean. Then they can, start the oxygenate the baby till the attending neonatologist is there. So to conclude, the 4th stage of labor is the most critical, as carelessness could lead to fatal consequences. The patient is carefully monitored and a record of vitals is maintained. Be vigilant. Keep patient and newborn carefully monitored. If PPH is detected timely in the golden hour, then with proper oxytocin and treatment, patient's life can be saved. Early latching of the baby to the mother's breast is mandatory, as it is helpful for the baby and mother because it causes release of oxytocin. So be watchful, be alert, make sure that both patient and newborn are well looked after. And before I say a thank you, you all are cordially invited to our National FOGSI conference on Scientific Sangam that is going to be held on 15th, 16th and 17th of December at Prayagraj. All are cordially invited, and please do let me know the topics you all are interested in, and accordingly we can, adjust. And another request to everyone is that please support me as I am standing for the post of FOGSI President, election year 2024. So thank you so much for your patient hearing.
Thank you, ma'am. That was such a wonderful talk. And I would now invite Dr. Nautiyal to please give her concluding remarks.
Thank you so much, ISOPARB, especially all Allahabadi girls, for inviting me, giving me this opportunity to listen to Ranjana. It was a fantastic talk, nothing left unturned. She was very right. When we were studying or we were working, there wasn't any fourth stage of labor, but all complications are occurring in fourth stage of labor. So what should we do? I don't think anything I should add in it, but only thing I want to state here, one is documentation. If the patient is bleeding and how much she bled and about the baby, documentation should be there, number one. Number two, as I did in my hospital, because that was the start of managing the fourth stage of labor. And we were being taught in different CMEs, in different trainings, how to protect your women going in bad shape in fourth stage of labor. So we put a chart in the labor room. Before the nurse come and call you, the doctor, if she's not there, she can manage something. So we made a flow chart, what she has to do. She has to give ringers, she has to give oxytocin, she has to do this, she has to put her hand on the abdomen of the patient, like Ranjana had said, and the baby is taken care, because I think most of our hospitals are having now neonatal unit, and I'm thankful to the pediatrician. They are present at the time of the delivery over there. Dr. Ranjana, thank you very much for this such a good talk. And nothing to add in it, but only the documentation and the chart in the labor room I will like to say. And I am sending blessings from Devbhoomi, Uttarakhand for your next tenure, President FOGSI. So
Thank you so much.
Ranjana, you have thoroughly covered everything, except
ma'am.
that a few things which may not be very common to this. Only that if you have a patient of hydramnios, you have to be very, very careful. Number two, if the twins is there, the person has to be very, very careful. For prevention, see the placenta always to missing lobes, or see for a tiny blood vessel which is torn at the edges, so that you can find out there can be placenta suction, churatia. The other thing is, when you've already said that it is the hemodynamics that is much more important. So now we have added the shock index to find out whether the lady is bleeding or not. So, and the fourth thing that I would like to say, that whenever we are stitching the cervical tears, because the blood vessels retracts about 1 millimeter or 2 millimeters above the apex, so your final or the uppermost stitch should be at least 2 mm above the apex of the cervical. Thank you. Thank you.
Thank you, ma'am, for your so valuable inputs. Thank you, ma'am. And now we will move on to the second session, which is the golden hour of breastfeeding. For this session, I would like to invite our esteemed chairpersons, Dr. Manisha Gupta, ma'am, and Dr. Gurpreet Batra. Dr. Manisha Gupta ma'am is a senior practicing obstetrician gynecologist, presently based at Wilson Medicity, Lucknow. She has been the ex-superintendent-in-chief Women Hospital Prayagraj from 2016 to 2020. She was the ex-counselor at IGNU from 2001 to 2004. She has represented UP in international training program in community-based RHNFP in Indonesia in 2001. She has been the master trainer, laparoscopic sterilization, PPIUCD, RT and IST. She has attended many national and international conferences as faculty as well as delegate. She has memberships of FOGSI and life membership of IMA. Her fields of interest include adolescent reproductive health, family welfare management. Welcome, Dr. Manisha Gupta, ma'am. And our other chairperson is Dr. Gurpreet Batra. She is a consultant gynecologist and infertility specialist at Cloud9 Hospital. She's a member of the editorial board of ISOPARB Prayagraj. She has been an ex-registrar at Max Hospital, Saket, New Delhi, as well as Maulana Azad Medical College. She has received training in hysteroscopy from Dr. Osama Shauki Training Academy, training in ART from ICAT Academy, New Delhi.
On behalf of Team ISOPARB Prayagraj, I take this opportunity to welcome Dr. Binal D. Shah to our webinar. Ma'am is the National Chairperson of IMS Club 35, Public Awareness Committee 22-24. She's a Senior Consultant Gynecologist and Laparoscopic Surgeon at Dwarkesh, Baroda in Gujarat. She's an MD, Gold Medalist from MS University and a Diploma in Gynae Endoscopy from Germany. She's also a consultant with PCOS Club India. She has been the past president of BOGS and Menopause Society of Baroda. She's a FOGSI representative from BOGS. She has been awarded for the Best Paper Award at IIG Conference, a Best Video Presentation in Ahmedabad, and many more awards in her name. We have a nice long CV with us. And also, ma'am has been Mrs. Fit and Glam Pageant winner, Mrs. Rajasthan. That is a wonderful achievement, ma'am. And she holds a special interest in laparoscopy and women health awareness activities. We welcome you here, Dr. Binal.
Yeah. Thank you for the kind words, Dr. Gurpreet. Thank you so much. And yes, this is a very vital thing which we are going to discuss today, because delivery is birth of two beings. Yes, it is not only one, but it is two beings. One is the newborn and one is a new mother. And these two new beings are under care of us, the obstetricians, the women healthcare provider. So we should not, go away from our responsibility that this is probably not our responsibility, but of the pediatrician, especially the first hour after birth, the golden hour, the baby is with us and we are responsible for this. Next slide, please. Yeah, we all know that milk formation happens from the lactiferous ducts, and they are the ones which carry them up to the nipple. What is important here that oxytocin is the hormone which makes these ducts contract, and prolactin is the hormone which makes them secrete the milk. So both these hormones are very, very essential for us, all the mammary animals. Next slide, please. And all the learned obstetricians here are aware that the prolactin reflex happens whenever there are sensory impulses from the nipple. Whenever the baby suckles, the prolactin is released in the blood from the hypothalamus and the pituitaries. And this prolactin is secreted more at night. And this also suppresses ovulation. That is why we know that the menstruation doesn't resume and often the pregnancy may not happen. Now, this reflex is very important. Next slide. And another reflex, next slide, please. Another reflex which Ranjana ma'am was talking about is very important. That is the oxytocin reflex. The oxytocin in the blood also helps the breast to contract and release. The milk ejection reflex happens. At the same time, this oxytocin also works on the uterus and makes the uterus contract. So this reduces the hemorrhage and the postpartum hemorrhage happening from the atonic uterus. So this way also breastfeeding will contribute to reduction in the blood loss post-delivery. Often your mothers would, kind of complain, the pregnant lady, that when the new mother, that when my baby is sucking, I feel a lower abdomen, some cramp kind of feeling. So just tell her that this is something which is normal and she should expect this to happen. And it is nothing but her uterus which is involuting and becoming more tighter. Next slide, please. Now we are all aware about the reflexes in the newborn. Next, keep doing the next because there are three. Yes, the rooting reflex, the sucking and the swallowing. So luckily a term baby who has a proper anatomy of the oronasal area has all these reflexes. And why this golden hour is important? Because in the first hour post birth, all these reflexes, the baby is very alert and these reflexes are perfect. So once rooting means whenever something touches the cheeks of the baby would turn his or her face towards that thing. So suppose the mother's nipple touches the baby's cheek, the baby would turn towards the breast. Sucking reflex, the baby knows how to grip a thing and start sucking, and that will help the release of the milk. And swallowing, after sucking and filling the mouth with the milk, the baby also knows how to swallow. So nature has already, set these mechanisms in place for the newborn baby. Next slide, please. Next slide. Yeah. Now, why we are so much emphasizing on the initial first hour and especially the initial 2-3 days? Sometimes some people would say that it takes at least 3 days for a proper milk to come, and especially mature milk comes normally after 5 to 7 days, and perfect milk starts coming after almost 10 to 15 days. But dear friends, we all know that first 3 days, the milk is the most important, which is the colostrum. And as you can see the difference in the composition of colostrum and the mature milk. Colostrum is much easily digestible because it is less of calories, less of fat. But the most important thing is the secretory IgA, the antibodies which are available. This is the baby's first vaccine, I would say. It will protect it from all the infections which a baby may be prone to. And it is rich in vitamin A, B1, B2, vitamin C. So all this, it is a perfect, composition to be given to a newborn baby. Next slide, please. And yes, initially there are a lot of myths related to colostrum. Like people say कि ये चेक है, इसमें पस है, बहुत गाढ़ा है. So on the contrary, we need to demystify these myths in the mind of the mothers and especially the grandmothers, or जो सासू जी वगैरह जो है साथ में, we have to demystify that this is the best milk for the baby, and even 1-2 drops is enough to give its beneficial effects. And initially the baby's stomach also has a less capacity. So don't feel that how the baby is going to be satisfied, how the hunger is going to be satisfied. And as I already told you that colostrum has more antibodies, more anti-infective factors. So this is protective. It has a mild purgative effect, so that will clear the gut of the baby of all the meconium. It has growth factors, so it helps the maturity of the intestine of the baby. Also helps in preventing any allergies to the baby and intolerance to the food. And as we discussed, it's rich in vitamins as well. Next slide, please. And we are all aware, but it is very important to put such posters in the antenatal area and in the delivery room. You need to start preparing your patient for breastfeeding mentally and physically from the antenatal period itself. Keep on re-emphasizing the benefits of breastfeeding so that the woman is mentally and physically ready to breastfeed. And on the contrary, she is kind of eager to breastfeed. So we know that it is a complete nutritional supplement for the baby up till 6 months exclusive. So you don't need to give even water to the baby till then. And gradually you can start the weaning products, but you need to continue the breast milk for more than 1 to 1.5 years at least. And it provides adequate calories just right, no excessive proteins or fats. It's just right composition for the baby. And it's not only a benefit for the baby, but it's a win-win situation. The mother also gets benefited because there is reduced post-delivery bleeding and anemia. It helps the uterus to get involuted faster. It helps the mother to lose the excess fat which she has gained during pregnancy. It helps her to lose and become more fitter. And it is also protective against breast and ovarian cancers. Next slide, please. So yes, these are the best. So these are the posters. Keep clicking the next. Yeah, next. And we also have seen that because of the presence of DHA, the breastfed babies, they have higher IQs. It is the perfect nutrition and no infection. So the baby falls sick less often. It also prevents the baby from all the chronic diseases. It is even said that the breastfed baby is less risk to asthma or obesity in adulthood. So so much beneficial is the breast milk. So these kind of posters we put in the nursing rooms. And yes, it is easily digestible. Next slide, please. And these are, keep clicking, yes. So these are the benefits to the mothers, which we just right now, emphasized. And yes, no preparation is required. Just mother needs to open up the buttons and she is ready to feed the baby. So there is no need of any sterilization or anything which is required. And next slide. And there is a lot of bonding which happens between the mother and the baby. The baby gets the warmth of the mother when the baby cuddles to the mother. So there are a lot of benefits and bonding which happens. And less the baby falls sick, the less is the absentees of the mother. And there's a lot of benefit to the society as well. Because, if you will count how much financial burden would be there to a family when they have to procure a lot of formula feed ka dabba, it is so costly, plus the bottle and the sanitization and sterilization of the bottles, the nipples, and the baby falling sick because of the bottle feeding. So that again increases the cost of the medicines and all. So economically, if you also see, breastfeeding is much more beneficial to the society as well. So these are the recommendations that you should breastfeed the baby immediately after birth within the 1 hour. That is what we are talking about, the golden hour. Immediate skin to skin contact, that Dr. Narendra Malhotra sir was already telling us about the breast crawl, that you don't need to do any resuscitation also. The baby who is crying well, you can just wrap dry and then just leave the baby, and the baby actually can crawl. And, obviously you need to support the baby so that the baby doesn't fall from the table and all. But, the baby can directly have that smell and perception and can suckle to the breast. Practically what we are doing is, because of the presence of the pediatricians in the labor room and the OT, obviously they are the ones who take the baby first, wipe them dry, do the naso-oral suction. And after that, tying the cord, they hand over. So in our practice, in my nursing home, within 15 minutes of delivery, may it be a cesarean or a normal delivery, the baby is on the breast. And all the nurses in my nursing home, they have been trained as the lactational counselor consultant course they have done. So they exactly know the perfect way of latching and, how to hold the baby and everything. So this is what is important, that you have to give a holistic and a comprehensive care to the mother and mother-baby as an entire unit, and not only the mother. And what is most important is that no pre-lacteal feeds. Like the grandmother would come ke shahad chatana hai, batashe ka pani chatana hai. So that is what we need to emphasize, that no pre-lacteal feeds. Directly what we'll be giving is the colostrum. Next. Yeah, so again, what are more important things which we need to take care about is the right posture of the mother. Like she has to sit straight with her back supported, or if she is immediately postpartum, as we are talking in the golden hour, she can just lie on the side, but mainly she has to be made comfortable. Next slide, please. So these are the various positions. Next slide. Yeah, and what is important for the right posture of the baby, that the head and the body of the baby has to be in the straight line. The face is facing the breast, the nose is opposite to the nipples, and body is close to the mother, like, kind of baby is stuck to the mother's body. And then the mother has to sit straight. The baby is lifted up if required with the help of a pillow or something. The mother should not lean forward. Next slide, please. Yeah, and this is how, breast is, like, they have shown the example of a burger, that the baby needs to open the mouth properly. So what needs to be done is that you have to touch the nipple to the nose of the baby. So the baby will open the mouth wide open. And once the mouth is wide open, the mother is taught, or initially the nurse can do in the first initial 1 hour, hold the breast and kind of bring it towards the baby by compressing the areolar portion of the breast so that it is in a good grip. Next slide, please. Yeah, so these are the various positions which you can teach to the mother. Obviously, in the first hour, the lying down is the most comfortable. But as the baby grows and as the mother is more confident, you can teach her the other positions of how to hold the baby. Next slide. And yeah, next slide, please. So perfect latch is very important. And this is the rooting reflex. As I told, stroke near the corner of the mouth. The baby would turn its mouth towards the stimulation, then touch the nipple. So baby will open the mouth. Next slide. And then it will grab. So wide mouth opening and using the sandwich hold of the breast, the baby is made to hold the areola and the nipple. Next slide, please. So it is important that this is the correct latch, where the nose of the baby is free. Most of the areola is hidden in the baby's mouth and the lips are flanged outwards of the baby. and the chin of the baby is touching the bottom of the areola. Next slide, please. So that is a perfect, correct latch. Next. Keep clicking, please. Yeah. So as I told you, these all signs you have to look for. So please put such posters so mother would know that this is the sign of correct latchment. And she is often worried that bachche ka naak dab jayega. So you have to tell her that even if one nostril is open, that is enough for the baby. Next slide, please. Yeah, and this is incorrect. Only baby holding only the nipple and not pressing on the areola is a wrong technique. And this leads to inadequate milk secretion, also leads to sore nipples and cracks on the nipples. Next slide, please. Yeah, so this is a correct latchment. Next. Yeah, and as I told you that causes of incorrect latchment may be that you have used some feeding bottles, so there is nipple confusion. Sometimes the mother is inexperienced. There is no skilled support to her. Next, please. And this would happen as a consequence of incorrect latchment. There will be sore nipples, engorgement of the breast, and breast abscess could also happen. So what we want is a pain-free, efficient milk ejection. Next slide, please. Yeah, so this is what is good and what is bad latchment of the baby. Next slide, please. And keep clicking, please. So what is important is that the mother's confidence really helps and plays a part in the milk transfer. Next slide. When the mother thinks lovingly of the baby and she's confident that when God has sent the baby, the nature is going to send the food for the baby. That way she's confident, she's happy with the sound of the baby, then automatically the milk reflex will occur. But if she is in pain, the episiotomy or the sutures are hurting, she's worrying whether my milk will be adequate for the baby, she is in doubt on herself whether she'll be able to take care properly or whether she'll be able to feed, or whether her baby is the milk is adequate for the baby, then probably the milk reflex would be reduced. Next, please. So we need to, look into all these maternal factors, and as healthcare providers, we need to intervene wherever the problem is happening. Next slide, please. So please, insist upon early initiation of breastfeeding. So this is what is being also told to all the ASHA workers and Anganwadi workers, and it is being taught that they are not supposed to give the baby any honey or shakar ka pani ya gud ya gutti, janam gutti, aisa kuch nahi dena hai. Next slide. Yeah, next slide, please. And so once you don't give any prelactal feed, automatically the baby would try to suck and the desire for the breast milk will be there. Next slide, please. Next. Yeah, so these are the major hurdles that, family support is not there, or health. Nowadays, because of nuclear families, we, the healthcare providers, have to, kind of provide support to the new mother. And there's some commercial influences of the ready-made powders which are available for the baby. So formula feed, advertisements also lure the mother that it is better to give that, it's easier to give. And often the mother is not confident that she'll be able to produce enough milk for the baby. Next slide, please. Yeah, so important do's are that within first half an hour of the birth, the breastfeeding should be initiated. No prelactal feeds, no artificial teats or pacifiers, no bottles. And successful breastfeeding, you have to initiate, and also your nursing staff has to be incorporated. And this is the Milk Substitute Act, which is amended. And as a hospital, we should not be promoting any formula feeds in our hospital. And even if you will see carefully on the dabba of the formula feed, it is written, mother's milk is best for the baby. Next slide, please. Yeah, so these are the messages that we have to initiate feeding within 30 minutes. No prelactal feeds. And successful breastfeeding is that it is on demand, nothing like a timely feed, and correct position. You have to increase the mother's confidence. Next. And no bottles, as we already said. And you have to, next please. Yeah, you have to let her overcome of that feeling of not having enough milk. You have to reinforce that confidence in her. More the suckling, more the effective suckling will happen, more frequent, automatically more milk will be produced. Next slide. Yeah, so in the World Breastfeeding Week, this time the theme given was enabling breastfeeding, making a difference for working parents. So nowadays, as the mothers are working, we need to, see to it that she gets adequate leave and has the time to feed the baby. At the same time, in the workplace also, the changes have to be made, either crutches or she can be given intermittent leave in between to continue breastfeeding the baby. Next slide. So we are looking towards sustainable goals and towards baby-friendly hospital initiative. And FOGSI has also tied hands with WBW, that is the World Breastfeeding Foundation. And there are 10 steps to a baby-friendly hospital. Next slide, please. Yeah, so I'll just quickly take you through the 10 steps and we'll be completing the talk. So you have to enforce the rules of the breast code of conduct. You have to evaluate, and there has to be an infant feeding policy. Establish the breastfeeding and lactation. Next slide. And you have to empower your staff with the adequate knowledge. You have to educate your patients themselves during the pregnancy period. Next slide. Yes, you have to start counseling, preparedness them for the breastfeeding, correct technique. If the nipples are inverted, try to correct it in the antenatal period itself, rather than, facing that challenge after delivery. The family has to be there to support. Early initiation is the most important point, and major role of obstetrician is here. Nursing staff should be trained accordingly. Breast, crawl, and kangaroo care we discussed. Next. And you have to support the mother and manage whatever difficulties are arising. Suppose sore nipples, engorgement, any other problem like pain in the stitches, you have to take care of that as well. Next slide, please. So exclusive breastfeeding and emphasize on the importance of colostrum and milk, breast milk as a complete food, and enable the mothers rooming in. Like there should not be no separate cot for the mother and cradle for the baby. Like I have removed all the cradles from our nursing home beds. So baby is exactly lying adjacent to the mother, rooming in, that is called, and that is to be practiced. And mother is taught how to respond to the infant cues for feeding. Next slide. Yeah, so educate and counsel the mothers about the risk of feeding from the bottles. And at the time of discharge, also keep an ongoing support and encourage them to come back if they have problems. Last slide, next slide, please. Yeah, and only in terms of preterms or anything where mother's milk is not available, you can take help of the human milk bank. So maternal nutrition and successful breastfeeding is not the sole responsibility of mothers. It is a societal responsibility, and we, the female healthcare providers, have to take this initiative to optimize the golden hour of breastfeeding. Next slide. And I would like to request all of you to support my friend, Dr. Archana Dwivedi from Baroda. She's a very good friend of mine, and she has been the founder president of Menopause Society Baroda, past president of Baroda Gynec Society, and at present, she is the website committee chairperson of IMS, and she is standing for the candidate of FOGSI Midlife Management Committee chairperson. So please support her for the same. And thank you, Ranjana ma'am, and thank you, ISOPARB, for this opportunity.
Thank you, Binal, for that appeal, because with my mentor, Dr. Manju Verma's madam sitting here, and you remembered our Mahakal thing, Ranjana madam here, and all the esteemed seniors and best friends over here. Thank you for bringing this. This is the first platform which I'm announcing, Manju ma'am, with yours and Ranjana ma'am's blessings. Thank you so much.
Thank you, Dr. Binal, for that wonderful talk. I would request Dr. Manisha Gupta to please give the concluding remarks.
So, good evening, friends. I am very thankful to the ISOPARB Prayagraj Society for giving me this opportunity. So, Dr. Binal has explained beautifully each and every part of the breastfeeding after the birth, care of the baby, care of the mother, and benefits for the baby, benefits for the mother. But we should know what is the golden hour after birth. It is the time. Time is very important. Just after birth, it is 1 or 2 hours, skin to skin contact, uninterrupted with the mother. As the journey of the baby and the mother during labor and delivery is very hectic, and they are very fatigued. So it is the golden hour after birth is the sacred time for the birth parents, that is mother and baby. This golden hour is simply uninterrupted time. Delivery causes lots of stress to newborn mother and the baby. Both of their bonding go through so much during labor and delivery. So golden hour is essentially to help minimize stress and promote a calm and healthy environment both for the mother and the baby. There are multiple benefits for the fetus, when it is uterus, and the journey from the uterus inside and the uterus outside is difficult, and baby has to adapt herself or himself to the external surroundings. But it is not always possible. Birth is very unpredictable, and the opportunity for the golden hour is not always possible. when there is some emergency with the mother or the baby is premature or there is some accidental hemorrhage or there can be number of reasons. But as soon as the baby and mother both are comfortable, we should avail the benefit of the first hour of the golden. What are the benefits for the baby? Benefits for the baby, immediate benefits and the delayed benefits. In immediate benefits, there is control of the temperature. With baby's first cry, there is expansion of lung and proper functioning of the cardiothoracic body function. There is, when the baby suckles, there is lactation is started, and in lactating milk, there is lots of antibodies, proteins that are very beneficial to the baby, and that is seen in the later life of the baby. Because with the development of the baby, there is it has been seen that the breastfed babies are having more IQ. There is less of development of diabetes, obesity, and some many more diseases. Less childhood obesity is also decreased in the breastfed babies. For the mother, it is also very beneficial because.
Thank you, Manisha ma'am. And now we move on to the panel discussion on problem solving in breastfeeding. We are privileged to have Dr. Manju Verma ma'am as expert for this panel. And ma'am really needs no introduction. She's teacher of teachers and we all are in awe of her academic knowledge. She has been the past president of UP chapter of OBS-GYN. She is retired professor in HOD. She has
I think I am one of you. That is more than enough for me as an introduction.
Welcome, ma'am. And the moderator of this panel discussion is Dr. Charulata Bapaye. And she is the director of GEMS Hospital and Endoscopy Center at Ashwin Hospital, Pune. She is the chairperson study on female breast committee FOGSI. She is the clinical secretary of POGS. And she has presented numerous videos and presentations at national and international conferences. She is the recipient of Smita Jog Award in 2019 for exemplary work in adolescent health. And she has recently won the Woman Entrepreneur Award through Rotary Pune, POGS Idol 2023. And she has been awarded the MS Signature International Award 2022 for being an amalgamation of academician and public health expert. Welcome, Dr. Charulata. And now I would quickly introduce our expert and experienced panelists. Dr. Amita Shah, she is the president of Baroda OBS-GYN Society. Dr. Arshna Dwivedi, past president of Baroda OBS-GYN Society. Dr. Anubha Srivastav, she is the professor, head of department pediatrics of MLN Medical College, Allahabad. Dr. Chitra Pandey, senior gynecologist, vice president of ISOPARB Society, Prayagraj. Dr. Uma Jaiswal, secretary, Allahabad OBS-GYN Society. Dr. Lakshmi Singh, senior consultant at Parvati Hospital, Prayagraj. Dr. Shikha Maurya, consultant gynecologist at Shikha Hospital, Prayagraj. And now I request Dr. Charulata ma'am to kindly conduct the panel.
Thank you so much for those kind words. And at the outset, I would really like to thank Dr. Ranjana ma'am for this wonderful invite and for this wonderful opportunity to interact with her and all you esteemed faculty of ISOPARB, Allahabad and Baroda societies. There are many friends and many new ones that I'm going to make today. And I'm indeed privileged to have none other than Dr. Manju Verma madam as our expert for today's panel, which is barriers to breastfeeding. I think Beenal has already done a great job. Beenal, fantastic talk. And I know the amount of work that you're doing. And although you're not an actual breast committee member, probably you should be given an honorary membership of the breast committee. Archana, good to know that you are, contesting for the upcoming elections. Best wishes to you. Uma Jaiswal, I have met on many occasions. Jyoti ji to kya badi achhi friend hai. I can just see Gitendra Sharma sir and Amita Shah ma'am, Sarveshwari ma'am. Everybody are friends, and as I said, now we are making newer friends. Before we start, I would just like to make a small mention that this is the first time that the Breast Committee FOGSI has come out with a textbook on breastfeeding, which is exclusively for the gynecologists and obstetricians. All these days, we were having textbooks for the lactation consultants. That was one thing. And we have a big chapter on the golden hour by none other than Dr. Narendra Malhotra, sir. So we are also coming up with good clinical practice recommendations for breastfeeding. So a lot of work is being done on the field of breastfeeding as well as breast health. And so here I will be sharing my screen and we're going to have some great interaction with our esteemed expert and panelists. I welcome our expert, Dr. Manju Verma, madam, and our esteemed panelists, Dr. Amita, Archana, Anubha, madam, Chitra Pandey, Uma Jaiswal, Lakshmi Singh, and Shikha Maurya. So breastfeeding is a mother's gift to herself, her baby, and the earth, said Pamela Wiggins. Breast milk, which is often referred to as liquid gold, which also happens to be the name of our textbook, which we have just launched. It is nature's remarkable gift to newborns. It goes beyond mere nourishment, fostering a profound bond between mother and child and laying the foundation for a lifetime of health and well-being. However, it is not an easy task at all. There could be a number of difficulties that the new mother has to face, and that is exactly why we are here to discuss the various kinds of problems that this new mother can face and how we as obstetricians can help to minimize them or help her to put her at ease, her and her family. I think a lot has already been spoken about the benefits of breastfeeding to the mother as well as to the baby. And so we're just going to move ahead to the aims of today's panel discussion, which is to identify the various maternal, infant, and physical barriers to breastfeeding, enumerate ways to prevent them, find a solution to most of the problems, and try to achieve 100% exclusive breastfeeding rate in all mothers. I think probably that is the most important goal that we as breast committee people are out to achieve, not only in India, but all over the world. So I think why don't we move over to Dr. Amita madam and ask her as to what does she perceive are the barriers to breastfeeding. Amita ji.
Yes, actually, madam, first of all, the mother has to learn what is the correct position of the baby. She needs to have the proper support of the baby, of her position. From the family also, she should have a support. And as told so much of the now, we should use the one golden hour, we should not waste it, and then she will be very fine, and the baby will be very much willing to take the breastfeeding. At the same time, we have to examine the local examination of the breast also. Suppose if there is any sore nipple, cracked nipple, or inverted nipple, that we have to look for. So there are, first of all, the mother also should be willing to give the breastfeeding. That's what we have. She has to be motivated during the antenatal period. Correct. So these are the few things which are usually the barrier for the starting of the lactation.
Absolutely, madam. Very well said. I think the most important point is talking to the woman during the antenatal period.
Educate the mother.
Educating them, because what happens, we most of the time start talking about breastfeeding after the baby is born, which is probably a little late. It is just like any new skill, and she has to at least have some knowledge about what she is in for. And so the common barriers to breastfeeding that we face are mainly lack of confidence in the mother, a belief that breast milk is not sufficient. I think all of us as obstetricians, probably we have 70% of our mothers coming and telling us, Dr. Ji, mujhe lagta hai mujhe enough milk hi nahi hai, kya main top feed de do? So we have to talk about this point. Lack of an adequate support system. Today we have nuclear families, only the husband, wife, maybe some one relative to help them out. So it is our duty. We have to become a very active support system to this particular young mother. Whether if she has previous breast surgery, she's unsure whether she can breastfeed, if she's undergone surgery for CA breast or maybe a breast abscess or a fibroadenoma, she doesn't know if she can breastfeed. As madam rightly mentioned, there can be problems in the breast like engorgement, cracked nipples, sore nipples, retractile nipples, and sometimes embarrassment by the to the mother, because today in a country like India or anywhere else also, breastfeeding in public is not so very well accepted. Sometimes the first baby is very small and there is jealousy on the part of the sibling. Sometimes there is a chronic illness in the mother, postpartum psychosis. All these problems could be the barriers to breastfeeding, and we are going to discuss them as and when. So, Dr. Archana Dwivedi, this question is for you. This is a young girl, Pooja, 35-year-old. P1L1, she comes to you 7 days after her delivery. She is very anxious and she says she's producing less milk because her baby is crying a lot and always seems to be hungry. How will you proceed with this particular case?
See, Charu, this is a very challenging case for all of us, and it comes daily in bulk because most of the FIMEs who are coming in the elderly age group is going to be the problem, because most of them are working and they are not well counseled, as you already said. I think Peenal's lecture was very fruitful because we need to tell them in advance what is breastfeeding and when. I mean, I start teaching my patient immediately from the 5th month of their pregnancy. The breast care is very important. And the anxiety has to be settled by one-to-one talking first of all. And this is a very common problem that I'm not able to produce milk enough for the baby. So this is where the point of reinforcement, point of counseling it every minute that she is producing enough milk, and she has to self or auto-instruct herself first, because there are relatives who are already jumping onto the conclusion, Gai ka doodh de do, ye de do, wo de do, because you are not able to supply properly.
Absolutely.
And second part, which is the crying of the baby, this is the most common thing, which is very worrisome for any of the mother. So let's soothe the baby and then again lash on, and it has to be a repeated process. She cannot do it alone. So the family members or the maids sometimes, who's there a full-timer to us. I think I train the maids also who are living with the patient when she's a working lady and a nuclear family, because proper lash on and to help her during that, especially when she's a cesarean case or episiotomy case. Sitting is a problem, holding the baby is a problem, from like picking up the baby is a problem. So this is a psychological component which has to be handled very wisely and with a one-to-one interaction, and most of the problems get solved by this. Second part is that if the baby is wanting to feed, she's passing he or she is passing regular stools, and the burping is there. So I think the mother is having enough milk production, baby is getting satisfied. The second part comes the examination, Charu, that we need to examine her breast.
Why don't we first ascertain as to how will you, make sure that yes, the mother is producing enough milk. We how many stools does the baby have to pass? How many times the urine has to be passed? Because as you rightly said, most of the time it is a perceived notion that there is less milk. We have to understand that when the baby is born, the size of the baby's stomach is as big as a marble, only as big as a marble. So whatever few drops of colostrum are being produced and the process of suckling, these two are going to be more than enough for the baby to attain satiety. Okay, so I think we need to let the, I think we can ask Dr. Uma as to how will we gauge that whether the mother is really producing enough milk or she really has less milk, because there is perceived less milk and actual less milk. So we would want to ask Dr. Uma or anybody in the panel who would want to answer this question.
If the baby is getting properly sleep and proper burping is there, proper latching is there, no barriers are to discuss before, they are not there in the family. 8 to 10 times patient is feeding the baby and baby is gaining properly weight gain. Always baby is crying is not for the feeding.
Perfect.
Versus stool or versus urine or any abdomen neck. You have to examine for that baby.
Yes.
And check for the breast also.
Absolutely. I think checking the breast, which Archana was mentioning, is a very correct thing.
Yeah.
Because you have to look for the presence of fullness in the breast. You have the heaviness in the breast. So then that means that, yes, there is enough milk. I think we have Dr. Anubha. She's a pediatrician. Am I right?
Yes, ma'am.
Yeah.
Yeah. So Dr. Anubha, what would you want to say? How would you want to interact with us obstetricians? Because usually these mothers come to us that there is, I don't have enough milk supply. वो बाद में आपके पास आते हैं शायद, तो कभी-कभी हम, हड़बड़ा जा सकते हैं. So we would want your inputs also as to how we would be wanting to answer this question to the mother.
Yes, ma'am. There are, I think, counseling, as you all have pointed out, is the best way, and putting up numerical data is the best way to convince them. That is what practically I have seen. So we ask them whether the child passes at least 6 to 7 times he passes urine per day. So if the child is passing at least 6 to 7 times urine per day, day and night together, then that is sufficient, because milk is mostly liquid, and if it is producing that much of urine amount, that is sufficient. Second thing that I do is I put the baby on the weighing scale and I show the mother that the child is gaining weight. So then it's simple to say that the whatever is required by the baby, the child is getting that much milk, and rest, there is only one language for the baby, that is crying, whether he is wet, whether he has soiled, or whether he is hungry, or whether he just want to have a look at his mother. All he knows to do is cry. So don't take cry as a sign of hunger always.
I think that is a very, very, very important point, Dr. Anubha, that crying doesn't necessarily mean that the baby is hungry. It could be irritated, it could be sleep deprived, it could be tired, it could just be restless, as you said, it could be wet. So many other causes, and so it doesn't always mean that the baby is hungry. So I think
proper burping, then proper burping, then there is abdominal axe also. Baby can cry for that.
Yes, yes.
And if the baby has a full stomach, he will have a good sleep of around 1.5 to 2 hours, and that is sufficient enough.
Absolutely. Manju madam, you would want to add a little bit regarding
yes, I would like to say something, that because most of the times they fear in the minds of the new mother is that they're not able to feed the babies. Now one should now remember that when the baby is born on the day one, the volume of the stomach which can hold the milk is about 5 to 7 ml. So from 1 to 3 days, the baby may require more frequent feeds.
Yes.
On day 3rd, the size of the stomach becomes like a throat, size, which is approximately 27 to 22 to 27 ml. So the things will become a little easier from the 3rd day. From at the first week, it is like of an apricot, which is the volume of about 50 ml. So gradually it is increasing, and by 1 month is the size of an egg. So the amount is that initially first 2-3 days the ladies are very, very uncomfortable. So 5 to 7 ml, the colostrum will be enough for the baby. So the person don't have to worry. If the baby cries, there may be other reasons, as has been told. Or the other thing is the baby might be wanting the touch of the mother. So what one should do is to pull the baby over the shoulders and try to let the skin to skin touch is there. So the baby feels comfortable and confident, and the cry may become less. So this is what I can say. Yes. And the indicators you have already said, that the indicators are that, and by day 5, the color and the color of the stool should become yellowish, and there should be granules in it. So if that is there by day 5, I think the breast milk is enough for the baby.
So spoken like a true teacher. Thank you so much for that input. And now are there, we would want to talk about the causes of less milk supply. I think we'll move to Dr. Chitra for this particular question. There could be maternal causes and fetal causes which could be responsible for this low milk supply. So would you want to enumerate some, Dr. Chitra?
Yes, my maternal causes may be the poor nutrition of the mother.
Yes.
And the proper, yes, and the lack of the training or lack of the preparedness of the mother for the breastfeeding, as the emotional attachment with the baby and preparedness is very, very important, because it's an emotional reflex. The lactation reflex is the emotional reflex. So that is also very important, that mother should be properly explained the method of latching and how to position herself. And at least whenever we are suspecting that there is low milk supply, and before reaching to any conclusion, we should ask the mother to show how she is feeding.
Well said.
She should be explained that there should be proper exposure of the breast. She should be in comfortable position. Baby should be in comfortable position. And the various methods of breastfeeding should be explained to the mother. Wonderful. And very, very important, the one we have already explained, that the low milk supply, it is very important that the feeding is started in the first hour, because the baby is most active in initial half an hour to 1 hour.
Yes,
So it's
yes.
very important.
There, the activity, as you rightly said, the babies, why is the golden hour so important? Because the activity of the baby, the neurons, its reflex is extremely strong and powerful in that particular 1 hour. And so that golden hour is of immense value. So as rightly said by Dr. Keenan, that no prelactial feeds, don't give anything other than mother's milk and only mother's milk. So that was fantastic. We will be moving ahead. I think there are some fetal causes also of low milk supply, and Anubha, you could highlight these points.
Yes, ma'am. I think the most common scenario of low milk supply is the low self-esteem among mothers, because the moment the child starts crying, the whole of the family
we just want to talk a little about, these preterm infants where they're separated, or the baby is unable to suck because of these small problems. Like
there will be disparity, Charu, between the size of the nipple and the baby's mouth. So this is one of the things. There's sometimes there tongue tie and the oral any abnormality in the baby that needs to be ruled out.
Yes.
And sometimes like oral sores are also one cause because of the
candidiasis of the oral cavity. Absolutely rightly said. So I think especially if it's a preterm infant and the baby has been separated from the mother, we have to start pumping the breast. The more we pump, the more milk will be ready, and by the time the mother can go into the NICU, or the baby can be released from the NICU, the breast will be well functioning and the milk will be adequate. So I think even if there is a infant and mother separation, we have to make sure that we maintain the milk supply by pumping. We have fantastic pumps which are available.
Ma'am, if I can, that's why this new concept of family-based care is coming up in the NICUs and SNCUs, where actually NICUs are there's area where usually we used to keep it was all managed by staff nurse, but this new concept is coming up where the whole of the care of the baby is being handed over to the mother if possible, or one of the family members. So there is a family bonding. Yeah, we encourage the mothers to come up and clean the baby, change the diapers. And of course, all of us know about the KMC, the kangaroo mother care. So that is a big boon in stimulating the breast milk production in mothers.
Absolutely, Dr. Anubha. And I think I should congratulate Dr. Amita Tripathi, Dr. Ranjana, madam, for making sure that there is a pediatrician in today's panel, because it really makes a big difference, and such wonderful other obstetrician panelists with us. So Dr. Shikha, sometimes it happens that really there is less milk supply, and then how will we identify that there is definite less milk supply? Dr. Shikha.
Ma'am, thank you, ma'am. First of all, we should we observe this by asking history from the patient, whether the baby is passing proper stools or not, what is the urine output, that all we ask in history. And we also see during examination whether her breasts are engorged or not, or whether there is presence of any fissure or not, and presence of flat nipples is also seen. By that we can identify whether she is having really she is having genuine problem, or it is her perceived notion.
Correct.
And then we also inquire about medication history, because sometimes a patient is having suppose some cardiac illness and she is on diuretics. So in that case also there is decreased breast milk supply because it inhibits prolactin. And also we inquire about the bleeding of the patient, because if there is some retained bits of placenta, that also decreases prolactin secretion. So that can also decrease breast milk production.
Excellent answer. Absolutely excellent answer. And as far as the baby is concerned, I think, as obstetricians, we need to take a look at the baby also. And if the baby is looking a little dull, a little, listless, it does not appear satisfied, it is sleeping too long, as the mother says, or the urine is very concentrated, then yes, that means that there is less milk supply, and of course that the weight gain is not adequate. So now we move on to the
yes, should I add something? Please be sure that the patient is not taking pyridoxine, because pyridoxine is a suppressor and it is going to suppress the milk.
That is a point well taken. I shall read about it, because very often there is an element of postpartum depression, and we often give pyridoxine only for this postpartum depression. So we have to remember that. So that's a good take-home point, Manju ma'am. Thank you for that input. So I think we haven't spoken with Dr. Lakshmi. Dr. Lakshmi, how will you manage low milk supply? Is Dr. Lakshmi here?
Sorry, your slides are not moving. Exactly.
Yeah. Can you hear me?
Yes, doctor. Yes.
Your slides are not moving, Charu. Because of low milk supply, we are stuck there only.
Acha, is that so?
Yeah.
It's not moving.
They are not moving.
Oh my. This you cannot see? Management of low milk supply, you cannot see?
So we are on the slide
Causes
of low milk supply, but the question to Dr. Amita Shah, we are stuck there only.
I have no idea. Then has my slide share? Oh, resume share. Can you see it now?
Yeah. Low milk supply. Now it's fine. Yeah.
Oh, great. Thank you for letting me know. So, Dr. Lakshmi?
Yes. Can you hear me?
Yes, doctor. Yes. We were talking about management of low milk supply.
Yes.
Could you just highlight? So these all points have been talked about, but do you believe in any galactogogues? Do you believe in, any medications do you want to give? Do you believe in any dietary changes that you want?
Yes, in such patient, we have to take that the patient is taking a proper diet. Diet is very important because she is feeding her baby according to the position, and with the diet, she also have a adequate liquid also. Liquid intake be there. And other supportive treatment we can give a galactogenesis, which is not very important role, but we can assure the patients you continue the breastfeeding frequently with the proper diet and other things. So, and we ensure that the mother is not giving a top feed also, because so many times they are top feeding and they are saying they are feeding the baby. So we have to ensure that she is not top feeding the baby.
Absolutely. I think let us ask the panel whether what do they believe about the galactogogues, because I personally do believe in them. Can we have either Amita ji or Archana ji or Uma? What are their thoughts?
I don't think it works immediately.
Sorry?
It takes time to work.
See, Charu, galactogogues can be given as a psychological support to the mother, I would say, because actually when you are saying you're going to produce good milk by this, sometimes it psychologically acts. Because you give it and you're expecting a magic token, it's not going to be there. So here,
they are not much benefit, but for psychological benefit of the patient, we can give.
It's truly a psychological benefit. Yes.
Well, actually, we are having our GCPR and we have mentioned these galactogogues, and we do have a few studies which say that they do produce some help. And I think, things like fenugreek, shatavari, which are
metoclopramide we can give.
Homemade remedies are the better.
Yes, these are
homemade remedies.
Absolutely.
Yes. They do help. They do help.
Yes, they do help.
Yeah.
Absolutely. I would definitely go by them, and as you rightly said, sometimes it may be a psychological relief also to the patient. लगता है उनको कि कुछ दिया है डॉक्टर मैम ने, तो जरूर help हो जाएगी, and maybe
immediate period it is a psychological thing, but long term if you give, definitely help.
And I think we need to talk about domperidone, which is the only drug studied to increase milk supply.
Most of the time we give a domperidone.
Domperidone.
And metoclopramide can cause depression, and so we want to stick to domperidone. And of course, we have to make sure that there is a safe environment for the mother, either at her workplace or at public places or even in the home. You have a very tiny home, and if there are men from the family also in the same room, the woman might feel very conscious. So we have to make sure that she has adequate privacy during her breastfeeding. So with that wonderful session on tackling low milk supply, we are moving ahead to the next case, to Dr. Chitra. Dr. Chitra, this is a 32-year-old primey delivered 10 days back. She reaches the hospital with complaints of pain in both the breasts, especially at the nipples during breastfeeding. She also claims to have difficulty in breastfeeding. Now, what could be the likely cause? So we are now trying to establish the causes of painful breastfeeding. So, Dr. Chitra, over to you.
Ma'am, she is having difficulty in breastfeeding, and especially pain is in the nipples during breastfeeding. So first thing which comes to my mind is sore nipples or the cracked nipples, and it can be breast engorgement as well. So first we have to take the history, and then we have to examine her.
Yes, absolutely correctly. I think examining is most important.
Yes.
And we usually have these as the most common
Be
cause.
mastitis also, and
Yes,
in advanced stage, the breast abscess.
Yes, yes, absolutely. So these are the usual causes of painful breastfeeding. And so we're going to, try to tackle each one of them one by one. Okay. So Dr. Uma, suppose when you examine her, you see that this is how her nipple is. Okay. So what is your thought process, Umaji?
Ma'am, she is not there. She left some.
Oh, is that
I
so?
think I can take the questions.
Yes,
no problem.
Yes, please take
This is showing the flat or inverted nipple. So truly inverted nipple is very rare. So usually we tell the patient to just stretch the areola, or we can do this just to invert the nipple. Most of the time it gets corrected by its own. Second thing, we have to ensure that the baby is properly feeding. The mother should be hold the nipple to put it into the mouth of the baby properly. And even if it is not get corrected, then we can use the syringe, just remove the needle and fix it and do the plunger to be pushed up to correct the retracted nipple. Even if it is not possible, then you will do the nipple shield or a breast pump to correct it. And this has to be examined before delivery also. We have to check the breast examination when we are doing the breast examination before delivery. This is very important because the inverted nipple is present before delivery. It is never becomes after delivery.
Yeah. So I think Lakshmi ji, you have given a very, very correct answer that usually there is nothing that is very, very rare to find a true inverted nipple. It is usually just a flat nipple, and with gentle stimulation and manipulation, usually you can have a bit of the nipple coming out. The second thing we need to remember is that the baby will always latch to the nipple as well as the areola. So as you rightly said that when we examine the breast during antenatal period, even if you see a nipple like this, we are not going to comment that young lady, you have a flat nipple or you have an inverted nipple, because that is going to put her into a negative mindset. We are just going to see for ourselves, make a small mention on our antenatal card, but we are not supposed to discuss this with her at all, because she can go into a negative mindset. Previously, there was a thought that antenatally also we can pull out the nipple. Okay. Today,
it also stimulates the contractions also sometimes.
Absolutely. So today there is no, recommendation of pulling out the nipple antenatally. You would just tell her that she has to clean her breasts, and a gentle breast massage can be of help, but we are not going to ask her to pull out the nipples at all.
And in most of the cases, it usually protects in the later half of the pregnancy, or when the breast becomes full, it itself becomes protected.
Absolutely rightly said. So,
Charu, can I add something here?
Madam, yes, madam, please.
Since you mentioned in your book, I just went through the literature. And I found out that we all know that the progesterone, it is basically the contraction as being initiated by the oxytocin receptors. The oxytocin receptors are very, very less in the first and the second trimester. It is only in the third trimester and the initiation of labor, they are activated much more. And then the histology has proved from 300 to more than 2000 being from the time of delivery, the conception to delivery. So small amount of handling the nipple, I don't think it is going to make much of the difference, number one. Number two, the estrogen is the thing which is responsible for the activation of the oxytocin receptors. And we all know that the pregnancy is a state of progesterone, high progesterone. So unless the progesterone is taken away, the oxytocin receptors are not being activated. And once they are not activated properly, the contraction are not likely to be very, very strong. And the chances of having a labor is very, very, this is what the literature also says. Histologically, it has been proven. And in the past, we have been practicing it, but you don't have supposed to go on doing it. It is a gentle massage that the one can do it.
Yes.
7 months onwards, yes. 7 months onwards, yes, the oxytocin receptors are much more. But before that, it can be done. That's what I could gather from the
thought process is that we do not wish to put the mother into a negative mindset. that
Yes.
there is a problem with her nipple and she could have a problem with breastfeeding. Once that thought goes into her mind, then we have had it, because already it is a difficult situation.
Actually, it is the latching which makes a difference, because as much as the part of areola goes into the mouth of the baby, because the ducts are there only.
Absolutely.
So the ducts are there only. So if the contraction is being maintained and suction is maintained at the level of areola, the chances of milk coming out is there always.
Fantastic.
So this may be,
yes,
I think what I just wanted to add.
That is a point well taken, madam. And we are blessed to have you as our expert with so many inputs coming in from Manju ma'am. So now we move on to our next case. I just saw Uma. Uma, are you here? Or I saw her. I think
she is not here. She left.
I'm here.
Uma is here.
मेरा वो बीच में नेटवर्क चला गया था इसलिए
कोई बात नहीं उमा जी, तो ये केस आपके लिए है अभी. She is this para 1, delivered 5 days back, comes with fever with chills. On examination, overfilled tight breast with a shiny nipple, very painful with no milk flowing. So what do we think this is?
Maybe I have to examine the breast.
Yes.
It is around, maybe it is an abscess, because it is showing red. This is a erythema is there.
It is very slightly red, but it is very tense, shiny nipple. You know? And it is on the 5th day. It's on the 5th day. So
can we breast engorgement, heavy engorgement, baby?
I think it would be more likely to be breast engorgement, as you rightly said. And I think that for the benefit of all of us, although the topic of golden hour has been discussed already by Dr. Beenal, I think we should, just talk a little bit about how we can avoid this breast engorgement, because usually at least for 2 to 3 days, she's with us. So that is the main time when we as obstetricians need to speak with her, because this is a condition which can be avoided completely. So
we have to train our healthcare worker properly to proper latching, and training of the mother is very important. Apart from golden hour.
Yes, absolutely.
And we have to examine self also while discharging the patient.
Yeah, so that is one thing, but I think Archana, आपको कुछ add करना है इसमें?
No, I think this is a case of uniform congestion is there, so it is a case of engorgement only. Right. This patient may require a use of breast pump to release the milk, because otherwise any training won't help. The breast needs to be softened first. So
yes.
I mean, aggressive healthcare or ourselves, if we can spare time, this has to be a counseling and a pump extraction of the, I would go for, I don't want to name, but nowadays there are good breast pumps which are, there was a question in the chat box also, because you can liberally use it immediately in the, because just 5 days, you cannot just expect that she'll do everything in one go. So we need to make the breast soft. So I would like to intervene here. Even we can give an injection oxytocin sometimes with hot fermentation to help her. And painkillers obviously to relieve the pain.
Yes.
And I prefer coconut oil massage also gently on the breast so that the skin doesn't sore. Because you keep on pumping, you keep on doing everything, but the lady who's suffering needs to be soothed also.
Absolutely.
And mother should be explained the importance of frequent breastfeeding and the complete breastfeeding.
I think that is extremely important. Very, very well said, doctor. Is that first and foremost, she has to start the breastfeeding in the golden hour. Secondly, it has to be continuous, repetitive kind of breastfeeding. Even if the baby takes 1 hour at the breast, she has to sit with the baby accordingly, because that is the most important thing. The more the baby suckles, the more the breasts are going to, let down the milk, and it is not going to get accumulated. Then we have to relax the mother, keep her in a friendly environment, a little bit of breast massage before she starts the breastfeeding. After the baby has finished breastfeeding, if the breasts are still full and engorged, she has to empty them, completely, store it in a clean utensil which is kept covered. It can stay for 6 hours outside also. And I think that if they get engorged like this, then hot and cold compresses, alternate kind of, are definitely going to help to relieve the engorgement. And we all know the use of cabbage leaves. I think this is something very good.
Cold compression.
Yes,
Yes.
as
Cabbage.
cabbage leaves. You keep the cabbage leaves in the refrigerator, and they are very useful in relieving the breast engorgement. So I think that the breast pump has been talked about. We have to even know how to exactly express the breast milk, to start stimulating from the periphery, and then gently with your finger and thumb in position, you are supposed to squeeze all the milk out. So this is how we can help to relieve, and analgesic may be required as rightly mentioned. So this was breast engorgement, and as we said, prevention is better than cure. If she starts feeding in the golden hour, she's going to the chances are very less that she will land up in this thing. So I may be forgetting somebody. Dr. Shikha, maybe. Dr. Shikha, you're here?
Yes.
Yeah. So now suppose when you examine, there is no inverted nipple, there is no engorgement, but you just see that the nipple is kind of sore. So how are we going to help her? Or maybe it is slightly cracked, how we can say. What would
for that, first of all, most commonly it is due to improper latching of the baby. So we should teach the mother how to give the good proper method of nursing the baby. And then the saliva of the baby and the breast milk has got healing properties. So we should tell the mother to continue breastfeeding because it will heal. And the pain which the mother is having, that is relieved by proper latching technique. And if the pain is severe, then that side the breast milk can be expressed and given to the baby if the pain is severe. And as the pain slowly subsides, then the and lanolin mixed with breast milk is also applied. That also heals faster, and slowly it heals. And as the baby learns to latch on properly and mother learns to feed the baby properly, and there will not be any problem of sore nipples. And if the problem persists even after all these precautions, then we must rule out malignancy.
Fantastic. I think that was a very, very, very exhaustive and exclusive answer, Dr. Shikha. Congratulations for that wonderful way in which you put each and everything forward. I think we just want to make one.
We have to apply the cold compression on the nipple, never be the hot compression. Whenever there is a cracked nipple or sore nipple.
Absolutely, absolutely well said. The reason why, sometimes what happens, that the mother is breastfeeding. You walk into her room and she gets so conscious, she just sort of pulls the baby away from the breast and covers herself when she starts talking to you. So this is important for the mother to realize that she should not break the suction when removing the baby from the breast, because that can also give rise to a cracked nipple or a sore nipple. And we want to prevent this from occurring, essentially because otherwise you can have bacteria entering inside through these cracked nipples, and then you're going to have more of mastitis and more of breast abscess and so many other things. Right?
Yes, yes.
Good,
and the mother should be keeping the mobile, her remotes and glass water when she is feeding her baby. So she should be concentrate on the breastfeeding, never be.
Absolutely. I think that is very important.
Putting the baby away and
yes, absolutely.
Yeah.
The tender loving care, looking at the baby, touching the baby, all these things are so very important for the correct latch and for the correct positioning of the breastfeeding and all this.
And some mothers have habit of cleaning the nipples very frequently and rubbing the nipples, so that should be discouraged.
Very well said, doctor. I think that is again a very important message that we have to give, that she has to just wash the nipples just during her bath time. She doesn't have to scrub it at all. And as Dr. Shikha rightly mentioned, that the breast milk has got healing properties. Sometimes we use homemade ghee also, or we can use, of course, the mother's milk itself and
lubricant.
Dryness of the nipples should be avoided. Breast milk is best for that. Dryness of the nipples should be avoided.
Yes,
that's the main cause of
correct. Absolutely well. Absolutely. Okay. Archana, would you want to discuss breastfeeding positions and which, according to you, is the best position for breastfeeding?
See, Charu, it's a trial and error method for every mother. We cannot dictate any position to any mother. Cradle hold can be good for me, but somebody else would like to have there are different names. I would say the whole purpose is that hold your baby. What I tell my patients, don't try to manipulate the baby. Manipulate yourself, bend towards the baby in whatever position you want to. But initial few weeks, just sitting down position, holding the baby's hand in the cupping of the hand, And this should assist holding the areola to push the whole of the black part of the breast into the baby's mouth is more important. Baby should be well fixed on your lap. She can use a pillow covered with a towel or something and lean down to feed the baby.
Archana, do you really think, because if she leans down, she'll get a lot of backache?
No, but for the initial
mothers, that they should pull the baby towards their side.
His head should be pulled towards the breast.
Yeah, for the initial,
a lot of backache.
Let me tell you, initial few days, if she leaves, the baby is more receptive, and then later on, once they are more confident, they can just push back. And this is a practical problem which I'm telling you. Whatever we read and whatever we practice, sometimes there's a disparity. So initial few 1 or 2 days, or say 5 days, this is the method which I teach them. And slowly you see the grip is hold on the baby is very good, because to hold the newborn baby is a very difficult task for most of the mothers.
Correct.
So once they are fixed on the lap, they feel more confident that baby is not going to fall, and they can lean and do. And then in once within 1 or 2 days, the grip comes and they can hold the baby. I mean, it's just whatever suits mother and baby. The thing is that the nose should not be blocked, and the burping is the most common thing which should be practiced.
Absolutely, absolutely.
I think I cannot dictate the position.
As you rightly said, whatever position is comfortable for the mother and the baby is the best position for that mother and that baby. Even if she wants to feed in the lying down position, there is no problem at all. And as I think Vinal also mentioned, that no mother will ever crush her baby. So let us get out of that fear and just be relaxed that whatever position she's comfortable in, she has to continue to breastfeed her baby. So we
Ma'am, sorry to interrupt. I would request you to wind up in another 5 minutes.
Just last this thing, we will talk about the breast abscess. That's all, because it's an important thing to talk about. So we had why don't we just talk to our panelists as to, if now you have this breast abscess, you can see this tender, hot, fluctuating lump in the left breast. And
Yes.
that is involved, and here you can see that. Let us have a rapid fire session for this. I think Dr. Amita has had to leave, so I will start with Dr. Shikha. Dr. Shikha, what will you do? What is your diagnosis, and how will you manage this?
Ma'am, according to the history, the patient is having fever and fetal distress 10 days back, and having severe throbbing pain and lump in left breast. So on examination, this swelling is tense, tender, hot. Most likely it is due to breast abscess.
That's correct. You can see a little pus coming out over here, is it?
Yeah, pus coming out.
So sabse pehle, the first question to you is that, will you do sonography for her?
Yes.
Yes.
Yes, to confirm our diagnosis. Yeah.
Very often it is a very clear-cut kind of a picture. It is not mandatory to do sonography, is what I personally think. It is painful already, no? So with the probe and all. So sometimes only when you want to aspirate it, maybe you would want to place the ultrasound probe. That is one thing. Secondly, what antibiotic will you give this particular patient?
We give anti-staphylococcus in anti-staphylococcus first generation cephalosporin, because it is a milk collection, and milk is a very common nurture of the staphylococcal infection. And the first generation cephalosporin, we can give a cefazolin, cefadroxil, or cefzolin.
All
right. Amoxicillin, clavulanic acid combination.
That is also very good. Okay. We move ahead to Dr. Uma. Uma ji, what will you do for this patient? I mean, now she's come with this breast abscess. We have to treat her. So what is the commonest method of treatment for this?
Ma'am, I will like to do the aspiration.
Perfect, madam. Perfectly said. Okay.
Not incision. I like to do aspiration and send the pus for the culture aspiration.
Very well said. Very well said.
And meanwhile, I will start the mild antibiotics.
Yes.
And painkillers.
Well said. I think that
and cold fermentation. Cold fermentation, the patient has improved. And hot and cold fermentation simultaneously. Patient and mother is getting improved for this, and support of the breast is must.
Absolutely well said. Dr. Lakshmi, will you allow the mother to continue breastfeeding?
Yes, we have to allow the mother for the continue breastfeeding, alternate breast. We have to allow the mother to do a alternate breastfeeding.
Picture perfect. Perfect. Very well said. And only if it, if it is a very large abscess which is not responding to your repeated aspiration, only
Yes.
then
And
are
we
you
have
going
to give a small blood we infiltrate the skin with the 1% lignocaine and give a, with the 20 number blades, we give a small nick on the most prominent area and let the pus to be drained out. And with one finger, we have to separate all the septa inside the fibrous tissue. So all the pus which is accumulated inside should be completely drained out.
I think rather than taking
and call for the dressing alternative.
Yes, yes. So the point is, madam, we want to avoid this dressing part, and that is why, just aspiration with the wide bore needle is also sufficient.
Madam, we aspirate from the 16 number needle.
Taking lots of antibiotics, so the antibioma
sometimes it can develop, and if it is a large abscess, then of course you have to do IND. But if it is not a very big abscess, you should go ahead with aspiration.
Needle aspiration, yeah, ultrasonographic needle aspiration, definitely.
Ma'am, very important to explain to the patient that she will need repeated aspiration, because if you tell her beforehand, then she accepts. Otherwise, it's difficult.
Absolutely. These are the, so cephalosporins, erythromycin are considered safe antibiotics. If there are multiple loculae, then sometimes you do the aspiration under ultrasound guidance, because as you said that there are multiple.
One thing I would like to say over here is the incision has to be given at the most dependent part, and it should be radial, so that you don't cut the ductules.
Yes, absolutely right.
Even for ultrasound guided drainage, if we go through the most dependent part, that is important.
Yeah.
Absolutely. And so prevention of these kind of abscesses is most important, as we have already discussed, by the right way of latching. There is quite a bit more which is left, but I think I understand that we are running short of time. Some other time we will be discussing then. So can we have one take-home message from our expert and from each of our panelists as we wind up our panel? Manju ma'am,
I've already put my inputs, but only I think I would like to say, I would like to congratulate you, Charu. You have, covered almost everything in a very, very, explanatory way. So I must congratulate you.
Thank you so much, Manju ma'am. That's really, I'm honored it's coming from you. Archana ji.
Ma'am, I would like to add that for the working mothers, we should explain then that whenever they start working, how they can continue the breastfeeding, that expression of how long they can keep it.
But today we could not handle it because of lack of time. But that is a very correct thing. Is
I just want to explain to the mother, whenever there is engorgement, immediately you follow the consultant gynecologist or obstetrician, because once it becomes bigger, then it is painful and more difficult to manage for the patient also.
Absolutely.
From my side, Charu, listen, look, act with tender, loving care. That is the whole program for the breastfeeding.
Absolutely.
Thank you for making me a part of active things, whatever we are doing together.
Yes, indeed, Archana. Pleasure having you around always. Dr. Shikha, you want to give one take-home message?
Ma'am, one thing I wanted to add in inverted nipples, that many times we get inverted nipples in one side only, the other side is healthy, and there is a tendency of the mother and the baby also to latch on the normal side and not on the inverted nipple side. So we have to counsel the mother that you have to feed the baby from this inverted nipple side also, otherwise the breast will be engorged.
Fantastic. Chitra ji,
किसी भी हाल में breast feeding बंद नहीं करनी है.
Absolutely. Uma ji, Chitra ji.
Breastfeeding is the best milk for the baby. So we have to take care of this. Always do breastfeeding properly, proper technique. We have to explain the mother and अपने healthcare worker को भी properly training देनी.
बढ़िया. Very important.
There should be emphasis on the antenatal examination of the breast, so that we can recognize and
should be done in the first trimester.
Pick up the mothers who will need special attention after delivery. Like if they have a scar on the breast, or they have people or any other problem.
Yes, very well said. Very well said. Absolutely fantastic. Nautiyal ma'am and Ranjana ma'am, if you all wish to add one.
No. First of all, from the pediatrician who's on board.
Oh, okay. I'm sorry. Anubha.
Thank you,
Dr. Anubha.
Thank you, ma'am. So as I fondly say, whatever you sow, pediatricians, we as a pediatricians reap. So the efforts you start in the first trimester, second trimester, it ultimately leads to the healthy baby and the healthy practices and better management of newborns for us. So these forums like these and panels like these, when we have a coordinated discussions between pediatricians and obstetricians, that is the panel where we can pave the path for a healthier baby. So definitely counseling from starting from your end and continuing from our end will definitely promote and help us to achieve our ultimate goal of complete breastfeeding for all the newborns.
Wonderful, wonderful. So I think with that, it is time.
So ultimately, I just wanted to ask one thing. You all advocate aspiration now, and it's no more about incision and drainage.
Yes, madam, that is right. That is right.
But what if it is a huge, big abscess and
yes,
extremely tender, and you can see the pus points all over? Then also you like to just aspirate.
No. He just mentioned that if it is really a big abscess, then yes, IND becomes necessary. Or, you just give little local, as one of our panelists rightly mentioned, over there, and give a small stab also. That also works quite well.
But then until you break the locules, it will keep on recurring. So that will be a big problem for the patient, actually.
Absolutely, Ranjana ma'am. So what we usually decide is that the small abscesses up to 3 centimeters is what we believe for aspiration. And if it's more than 4 centimeters, we would probably want to go for an IND, which should be done by the obstetrician and not calling a surgeon.
Of course not.
Thank you so much for this opportunity. Thank you, Manju Verma ma'am. It was great, being on the same dais as you, and all our esteemed panelists, Dr. Amita, Archana, Umaji, Chitra madam, Lakshmi, Anubha, and Shikha. All have been great panelists. Thank you for this wonderful opportunity, and looking forward to meeting you all again and again. Thank you.
Thank you.
Naru, thanks a lot. It was very well done, panel.
Thank you, ma'am. Thank you, ma'am. We move on to our final session, which is a talk by Dr. Ishita Banerjee on legal issues and congenital anomalies of newborn. Our chairpersons for the session are Dr. Giteen Sharma sir and Dr. Jyoti Banglawala. Dr. Giteen Sharma sir, he is a practicing gynecologist and obstetrician of more than 28 years experience practicing in Ahmedabad. Sir is known all over FOGSI as medical counselor, and he has authored various books in law in obs and gynae, consents in obstetrics and gynecology, laws a doctor must know. Sir has been vice president of FOGSI and chairperson of ethics and medical legal committee of FOGSI. I welcome you, sir. Our second chairperson is Dr. Jyoti Banglawala ma'am. She is a practicing obstetrics and gynecologist with over more than 26 years of experience. Chairperson elect of ethics and medical legal committee of FOGSI. Currently, she is Vice President in Indore Obs and Gynae Society. She has various awards to her name, like Wonder FOGSIan Award, Nari Shakti Award, Corona Warrior Award, Dheera Award, and ma'am has also been invited as faculty in various national and international conferences. Welcome, madam. I now request Dr. Jyoti ma'am to introduce the subject and our speaker, Dr. Ishita Banerjee.
Thank you, Parul. And at the outset, I want to thank Dr. Ranjana Khanna madam. And thank you very much, Dr. Amita Tripathi madam, though she has not joined. And the ISOPARB Prayagraj chapter with the Allahabad and Baroda Society, all the seniors, especially Manju madam. I was actually I'm honored to share the dais with Manju madam and Sarveshwari madam, Ranjana madam, Narendra sir, Charu and Gitendra sir. And actually Allahabad Society and Baroda Society is actually home to us. Always encourages us. And Ranjana madam, she actually gave me platform. When I said her I want to enter in FOGSI, Ranjana madam is the one who said you should come, and she actually supported me like anything.
You're right.
Thank you, Ranjana madam. Thank you for encouraging me. Since actually I am knowing her since 2009, and since she is always encouraging for everything I was doing. And today I am actually humbled to come in this ISOPARB Prayagraj chapter, and it is my first webinar after the winning this ethics and medical legal committee election. So I'm actually happy to be here. And our today's topic is by Dr. Ishita Banerjee. She is the MBBS MD and the Fellow Indian Academic Echocardiography. Postgraduate diploma, she did the postgraduate diploma in clinical echocardiography and trained in pediatric cardiology at Ascot Heart Institute, Delhi. Her additional qualification is LLB and PG diploma in medical law and ethics. And her area of special interest is pediatric echocardiography, fetal echocardiography, and she is awarded Fellowship of Indian Academy of Echocardiography 2008 for the work done in echocardiography and for sensitization of practitioner towards congenital heart defects. She is having many publications in Index Journal of Indian Academy of Echocardiography and Index Journal of Indian Medical Legal and Ethics Association. She is faculty of Pediatric Cardiology Workshop at IAP National and State Conferences and IAP Medical Legal Group National Conferences. She was the Vice President IAP Prayagraj in 2023 to current, the Secretary of IAP Prayagraj in 2019. She is the editorial board of IAP Medical Legal Group and she is organizing pediatric cardiology conferences in Prayagraj in 2008 and 2023. Today her topic is legal issues in congenital anomalies in newborn. This is a very very helpful topic today for us all, because sometimes a newborn is viable, sometimes it's non-viable. So one must know about the congenital anomalies, one must know, and what should we say to the parents, what should we say to the attenders all over the when सब जब हमको घेर लेते हैं और बोलते हैं कि ये कैसे हो गया, and after 20 weeks of the viability, 26 weeks of the viability, and we came to know at the time of birth there's some congenital anomalies and they are saying it is a medical legal issue. आपको पहले कैसे मालूम नहीं पड़ा जांच में? So every aspect will be covered by Dr. Ishita Banerjee. Welcome you, madam.
Thank you very much. Thank you very much, Dr. Jyoti ma'am, for that elaborate introduction. And it is actually an honor to be here on this platform talking about this particular subject, which I think is very relevant for ISOPARB. And before I start with my talk, I would just like to add one thing to what Dr. Ranjana ma'am had said very early in the webinar this evening. She talked about fourth stage of labor being the grand finale. I'd like to add just one word to that, and that's hopefully. That's because every patient today is a potential litigant. So I think that rests in their hands. Anyway, yeah. It's not to scare you. We need to upgrade ourselves. We need to update ourselves to what's happening in the legal arena so that, we are equipped. It is not to scare us all from practicing, but actually we should be at least have some knowledge in the medical legal field. Anyway, so if I move on to my particular topic, legal issues in congenital defects, you see the society today has evolved significantly. The parents are very conscious. I mean, you hardly find anybody who's not attending antenatal clinics. So parents are conscious, the expertise, the medical men, their expertise has reached another level. So, and they are also conscious about the medical legal times. The technology, the advancements in the medical field, technology for prenatal detection, even that has surpassed all previous records. Now, having all that in place, how then are we in conflict with law when a baby is born with congenital defect? That is what we want to actually go through in the next 15-20 minutes. See, when a baby is born unexpectedly, the problem is when the baby is born unexpectedly with congenital cardiac defect, a lot of questions plague the minds of the parents. There are so many questions and they want answers to it. There is a blame game, there is finger pointing to each other, and of course the finger pointing stops at the doctor, no doubt, and it results in a litigation. I'll skip all the medical aspects because I don't think that is relevant for this talk. I'll stick only to the legal implications, and I would like to go about under these heads. See, for any legal implication, we need to have a doctor-patient relationship in place first. So in case of an antenatal care, for obstetricians, it's actually a dual responsibility, because the doctor is responsible for all the medical consequences of both the mother and the child.
Now, when a baby is born with birth defects, it is unexpectedly, without having been told in the antenatal period, it is obvious that it was missed. It is very evident that it was missed, and law has a particular legal term for it, a maxim called res ipsa loquitur. Res ipsa loquitur is it's simply a principle which translates to things speak for themselves. It's like operating on the wrong side, or something which is so evident that there is nothing to prove, and the onus of burden of proof falls on the defendant now. So the courts, in such cases, courts also apply this principle. I feel that we go through one litigation to understand or read the mind of the legal fraternity and the court. So here we have this landmark judgment by the National Commission in May 2016, and it kind of paved the way for future litigations. The story goes that Mr. Anil Dutt and Anju Dutt are married, and they have a baby, Simi, who's born with gross malformations. Now, in the antenatal period, 2 ultrasounds were done, one at the 21st week, another at 32 weeks of gestation by 2 different radiologists, and both reported it as normal. And there was a particular line in that report which read, fetal spine, trunk and limbs are normal, which we find in almost every radiology report. Baby Simi was delivered with no left arm, 1 kidney and damaged spinal cord. Now the contentions of the radiologist, the first radiologist, was that he was sent for an OBS USG. So only a basic routine USG was done. An anomaly scan was not done, and it is not possible to detect all the congenital anomalies in a level 1 scan. The radiologist 2, second radiologist, he also said that he was the patient was referred to him for a OBS USG, and so he had a targeted scan was not done, and he had reported IUGR and severe oligohydramnios, which itself further reduces the detection of limb reduction abnormalities. Now, in support of these radiologists, 4 expert opinions were put forth. One was an expert panel from the Department of Radiology, MGM Medical College, Indore. Another by the head of the department, Government Medical College, Nagpur, and 2 independent consultant radiologists. And all of them said that, yes, they are in agreement with the radiologists that it was not possible to detect congenital defect in level 1 or the basic ultrasound that was done, and that there was no negligence. Now, the complainants also put forth a expert opinion, and that of a forensic medicine expert, and they said that the forensic medicine expert said that there was gross negligence. So let's see what the court had to say. The court observed that 1, it is not mandatory to refer every case to medical board, and that doctors are reluctant to testify against colleagues, and that there is a conspiracy of silence. All the 4 expert opinions were dumped. They were totally trashed, and cognizance of the forensic medical expert was taken, even though he was not an expert in radiology. The second thing was that there was a specific mention of fetal spine, trunk and limbs are normal. Now, this was definitely taken cognizance of, and I would actually go ahead and say that it is a self-incriminating statement, because usually what happens, these are made on templates, and the abnormal finding is cut, copied and pasted on these. But when we fail to weed out the information that we have actually not seen, then it results in such kind of lapses. And of course, one cannot hide behind those. So this was a very self-incriminating one, actually. The court further said that the respondents' arguments were found frivolous, and that it's an ethical obligation to perform detailed ultrasound without strictly adhering to the words of the referral or prescription. Now, this leads to a little bit of ambiguity. Unfortunately, the obstetrician was not made party in this case, so we never had that version. But the ambiguity is that level 1 scan takes about 5-10 minutes. A level 2 scan takes, I think, about half an hour at least. And a level 1 scan costs 500, 600, 700 rupees maybe. And a level 2 scan costs about 2000. So one cannot be, one cannot assume that if you have sent an ultrasound, then a level 2 scan has to be done every time the patient goes to this doctor. Now, I think the only solution to this is communication. Communication, if we can have a word with the obstetrician, it takes a little time, but I think it saves years of litigation. And again, that, as I said, the res ipsa loquitur was applied on this particular case. And before I come to this, these were further judgments on June 2022, Nagpur, National Commission, October 2022, Odisha, July 2023, Karnataka, all similar cases. And in this particular case, the 4 ultrasounds were done in the antenatal period, but not one level 2 scan was done. Now, what we see is that there are 2 kinds of errors. There is either a cognitive error or a perceptual error. Cognitive is when you pick up something abnormal but misinterpret it. And perceptive is when there is a complete radiological miss. Now, again, let's look at the variables which can result to such a situation. We can have the machine, which may not be updated. The man behind the machine may not be expert enough or experienced enough. The maternal body habitus may not be favorable. The fetal position lie may not be favorable. Lighter may not be sufficient. And lack of communication between the radiologist and the obstetrician, I would say. And most importantly, it's also the psychophysiological factors affecting the visual perception of the operator. He might be just having a bad day. The radiologist might not be feeling good, maybe may not be feeling well, and or just overloaded with work, fatigued, or simply very busy. But none of these actually is acceptable in the court of law. Now, when we fail to detect what are the limitations besides the variables that we've spoken about, there are a large number of congenital defects. And for this, it's not possible to rule out each one of them, and highly specialized tests are required. And then comes the question of availability. Is it actually available in the tier 2, tier 3 cities? And if they are, then cost also becomes a limiting factor. And if the face of these kind of judgments, the fallout which I foresee is probably a blanket kind of an advice for all prenatal tests. Would that become a norm? That is again something which is very much debatable. I do not want to spend time on what's non-invasive and invasive. I think you all know far better. But ultimately, the final diagnosis is through full karyotyping. And for that, it requires an invasive procedure. And it has 2 major hurdles. One, that there is an increased risk of miscarriage. And secondly, the report also takes a couple of weeks. And therefore, the gestational clock has to keep ticking in your head, considering the MTP Act. Now, these are more cases beyond the structural defects. I think this Dr. Indu Sharma versus Indraprasth Apollo Hospital case is very, very relevant for all obstetricians. Dr. Indu Sharma herself, an Ayush doctor, infertility treated, underwent her delivery in Apollo. And she claimed that she was made to undergo a prolonged trial of labor and with excessive administration of syntocinon, which resulted in fetal distress. Then after birth asphyxia, baby landed up in cerebral palsy. Even though the doctor contended that the syntocinon dose that was given was well within the permissible limit, and the labor, the trial of labor given does not qualify for a prolonged trial of labor. But yes, the National Commission went on. These are all cases, they're all, most of these litigations, all of these litigations, in fact, are outcome driven. And once you do a retrospective analysis, it's easier to find faults actually. And the National Commission held the doctor liable. In Ritesh Kumar Garg case, the baby was born with Erb's palsy and doctor was held liable. In Jitendra Kumar Sahu's case, this baby had congenital heart defect. Fetal echo was not done in the antenatal period. Level 2 scan was done, but that was not conclusive for a congenital defect. And the obstetrician did not find reasons or indications that were suggestive to advise fetal echo. And the doctor was therefore not held liable. A word of caution for all the pediatricians, if there are still any in this forum today. Bedi Hospital versus Gurmeet Singh, we must not forget that, this baby had been taken to a doctor who was very experienced, senior, and expert in his field, and for simple vaccination and routine examination. And vaccination was done, but he missed out on a congenital heart defect, which was later picked up by PGI Chandigarh. And unfortunately, before anything could be done, the baby passed away. And the court held the doctor liable for not picking up the congenital defect. So I think vaccinations are contact points for us pediatricians for evaluation, re-evaluation, and re-evaluation. Next, after failure to detection, we come to disclosure. Disclose what? Well, disclose that there is a risk of conceiving a child with an abnormality. Even after having done all the tests, I think it's better to have a guarded approach. And it is important to tell them that there is a risk of passing on a genetic condition. We are unable to find out all the recessive characters or recessive traits in the family, which could be passed on to their prospective children, and the disclosure of the availability of all the tests, of all the prenatal screening procedures. Usually, we look at the socioeconomic background of the patients and hold our pen and refrain from writing tests, thinking that they may be unnecessary. I'll just give you this example again, another case, G. Vijay Shankar. G. Vijay Shankar and Chitra Vijay Shankar are married for 15 years. They have not conceived for 15 years. And they've tried every possible artificial reproductive technique, first in Malaysia, then in India, and with no success. And then finally, anyway, they conceive after an IVF in Madras Medical Mission with a twin pregnancy. One of the twin perishes. Now it's a singleton pregnancy. All is said to be well, and the baby is born with Down syndrome. Obviously, the patients go to the court saying that they were not informed about the prenatal tests, about the genetic tests, and if they were aware of it, they would have actually gone through it and then could have avoided the birth of a Down's baby. Now, the doctor contended that everything was explained to them, an NT scan was done. It was normal. The markers were not done because being an IVF pregnancy, and there was a chance of high false positive results. So the only way of confirming it was a full karyotyping, which required an invasive procedure and which threatened this pregnancy as well. So therefore, the parents refused to go any further. But unfortunately, I think after communication, the next most important thing is documentation. All this was not documented on paper. And the only thing that was written is that the parents say that they leave things all alone, to leave things all alone. And this one particular line on the prescription saved the day for the doctor, and the National Commission took cognizance of this and said that if such a line has been mentioned, then it kind of explains that a discussion must have preceded this, and the doctor was held not liable. So it is very, very important to write down whatever transpires with the patient party. It is better to have it on the paper. Now, after having disclosed all the possibilities, the next question or the next fallout of such disclosures are that there is an undue concern about minor defects. Say there is a small muscular VSD in the heart. And even though you tell them that the baby will probably spontaneously close, one can never be 100% sure, but one can only tell that this will probably close even after the baby is born, say within a year or so. But the parents choose to, they want a child without a blemish, and they would like to terminate this pregnancy. I think we must, this undue concern the parents need to be counseled, because such defects, if there is a child with congenital heart defect or any structural defect in this pregnancy, then it increases the probability of having such babies in the future pregnancies. So it's better to give them that information so that we can tell them, and it might be worse in the future pregnancies. So it is better to accept the lesser evil. However, at the end of the day, it is what the parents decide, it's what the mother decides, because despite the debate over the pro-choice versus pro-life, it is the bodily autonomy which has been given great importance by the courts, even the Supreme Court lately. So whatever the parents decide, ultimately it has to be followed, but it is better to counsel them of all, and all that has to be written down, because doctors will continue to stay in catch-22 situation. A baby is born, you can be sued for wrongful birth, or if you get all the investigations done, then for fleecing them. I would not like to go into all these court decisions on MTP for birth defects, but the purpose is to highlight the court's compassionate opinion towards Down's syndrome. Court says that if Down syndrome is not incompatible with life, then such a life should be allowed to live and prosper. Well, the next thing is the prescriptions. We all know the mother, the antenatal, in the antenatal care, she might actually have some chronic illnesses, chronic medical issues, or certain other issues, some cardiac issues, some other issues which manifest in this period and which requires certain treatment. But if the patient is referred to a physician, then again there has to be a communication between the physician and the obstetrician, so that the right course and the treatment and the pharmaceutical treatment can be decided for the mother. And expertise, these are very highly technical and specialized tests, and therefore the expertise also needs to be very, very rigorous. And before one gets down to practicing individually, it is very important that they have actually gone through a very strict kind of training program, and wherein they have been monitored, supervised through several tests before they can handle cases independently. Because we do need more experts, because it has to percolate down into the smaller cities and towns. A word on, we have already talked about consent. Yes, all information has to be given. It's an informed consent. So the parents can take an informed decision of whichsoever way, but an informed decision may be taken. Though consent, it is a fallacy of law, because howsoever much you explain to them, it is very difficult for them to understand or read it in your perspective completely. That is a little difficult. We face it every day. After having given the gravest of prognosis, they'll ask you, "Wo sab to theek hai, par patient ko kuch hoga to nahi." So that is a fallacy of law we have to accept. And finally, the last slide on confidentiality. We know that we have to keep all the patients' illnesses and data confidential. But in this particular case, this English lady, her father had Huntington's disease, and she claimed that she was not informed about her father's illness, because now she is symptomatic at the age of 40, and now her daughter has the probability of manifesting this disease, has 50% chance of manifesting this disease. And so she had actually sued the doctors. Though it is a case of the West, but will follow in our country soon. It's a very latest decision in 2020. So having covered the, well, this is a very general slide. That's it. I think those are the basic things I wanted to cover in the congenital defects. And thank you. And this is, by this, I just want to tell you that everything seems to be good till a litigation comes knocking our doors. Thank you.
Thank you so much, ma'am, for the beautiful talk. The question answers have already been answered.
Dr. Jyoti, would you like to say something since Dr. Gitendra has left?
No, ma'am. Actually, Dr. Ishita mentioned one case from the Indore, and that particular case was our senior. That gynecologist was our senior, and she seek help from Dr. MC Patel also. So many medical legal expert from our gynae, she seek help, and she clear cut gave her clean chit just because she sent the patient for sonography all the time. They recorded, they have mentioned about 2 sonography, but that particular doctor advised sonography for 5 times. And every time the same sonologist wrote on that, as Ishita madam said, the already printed note. Every time there was a printed note and saying the less liker, and then they defended like, due to the less liker, it is impossible to see the congenital defect. So gynecologist got the clean check. I have to say one thing. Many of gynecologists, they are doing sonography by themselves. So it is for our, actually it is for our, if you don't want to go in the litigation, it is always fair to send patient at least for twice, to send the patient to the radiologist for sonography. Though we are seeing our patient for fetal heart and everything, we are doing sonography in our clinic, but it is always advisable to send patient for sonography to the radiologist. That's what I want to say. And it's a very nice presentation, it's Ishita madam. And, nice to see all the case you have given. These are the all good cases. Every time we must know about those cases. Thank you, Ishita madam.
So my heartfelt gratitude to our chief guest, Dr. Narendra Malhotra sir, for sparing his valuable time and blessing the webinar. My thanks to our organizing chairperson, Dr. Ranjana Khanna ma'am, for the idea behind this successful webinar series of Art and Science of Birthing. I extend my gratitude and regards to Dr. Manju Verma ma'am for her pearls of wisdom. My thanks to our esteemed faculty, Dr. Ranjana ma'am, Dr. Beenal Shah ma'am, Dr. Charulata Bapai, and Dr. Ishita Banerjee for their lucid and well-informed lectures. My thank to our chairpersons, Dr. Sarveshwari Nautiyal ma'am, Dr. Manisha Goyal ma'am, Dr. Geeten Sharma sir, Dr. Jyoti Banglaw ma'am, Dr. Manisha Gupta ma'am, Dr. Gurpreet Batra ma'am for their valuable comments. My thanks to our esteemed panelists for the healthy discussion on the panel, Dr. Amita Shah ma'am, Dr. Archana Dwivedi, Dr. Lakshmi Singh, Dr. Anubha Srivastava, Dr. Chitra Pandey, Dr. Uma Jaiswal, and Dr. Shikha Maurya ma'am. My thanks to Allahabad Obs and Gynae Society for their association, and also thanks to ICOG for granting us 3 credit points. Thanks to my co-convener, Dr. Abhilasha Kumar, for the moderation of the webinar. And last but not the least, our constant academic partner, Jagsonpal Pharmaceuticals, and Dr. Deepika Chhabra for their association. Thank you, Allahabad and Baroda Obs and Gynae Society, and all the best who are contesting for the elections. Please do vote and support Dr. Ranjana Khanna ma'am for her candidature as FOGSI President, election year 2024. Thank you and a very good night.
Thank you, Ranjana madam, for giving us all the
Thank you so much for joining, everyone. Thanks a lot.